As the daughter of an infertility specialist, Emily Maxson grew up with a strong understanding of medicine and an appreciation for the role of specialists. But she also learned about the challenges of access and the importance of primary care. As a primary care physician and chief medical officer of Aledade, Emily helps independent primary care physicians participate in accountable care organizations, preserve their independence and financial viability, and boost quality and access for patients. In this episode of the Health Biz Podcast, Emily and I discuss the role of primary care, how physicians have fared during the pandemic, the interaction of technology adoption and reimbursement, and Emily's predictions, or at least her hopes, for the future. I'm your host, David Williams. Thanks for tuning in, and remember to subscribe to Health Biz. Emily, thanks for being with me today.
Happy to be here. Thanks for having me.
Listen, we're going to talk a lot about primary care today. And as we jump into that, what's your background? What's your upbringing? What did you do for education, and what did you do in your first few years of your career?
Well, I grew up in suburban South Florida. I had 3 older sisters, all of whom ended up in education like my mom. My dad was an infertility specialist, and my mom actually stopped teaching so that she could see to my family's every need. And I was the sole person in my family who followed my father's footsteps into medical school, though I opted for a career in population health. I did my college and medical school in Durham, North Carolina at Duke before pursuing primary care internal medicine residency at Brigham and Women's Hospital in Boston.
That's very nice. So it's like a northern migration, at least for a while, although I think you've snapped back. My brother did his residency at the Brigham in primary care as well. I don't think at the same time that you were there. It was just down the street from our house.
Excellent. Yeah, I definitely did a northern migration. I had stints in the middle in different public health jobs. I worked for the city of New York at one point. I took time away from medical school to work for the federal government at the Office of the National Coordinator for Health IT. So definitely worked my way up north to Boston.
Now that sounds good. Now your focus is on primary care, but you come from a background of in your family of somebody who's a real specialist. So how did you think about kind of primary care versus specialty originally?
We had a lot of clinically oriented conversations around the dinner table, as you can imagine. And one thing that always made me wonder and question, and we had some good deep conversations about this, was whether the entire population could access my dad's services and his practice's services. This was at a time before insurance coverage was widespread for infertility, before it was considered the condition that it is that really does merit and need treatment. And so he was seeing many people who had to self-pay for his services. He did the best that he could to invite others of lesser means into infertility treatment. And I was always proud of him for doing that. But it always made me think, gosh, in my career, I want to see to vulnerable patients. I want to make sure that in what I do in the future, I'm building systems and services that don't leave folks behind.
Yeah, infertility is probably maybe the specialty with the most dramatic disparities of access. Just thinking about the states where there's a mandate versus those that there were not, and just the ability to just sort of go through the whole process there. So that's quite striking, and good for your dad for trying to bring in others, but it's not an easy one. If you look at primary care, certainly evolved over your lifetime, and I'm sure when your dad and even before that, were involved in medicine. How have you seen the role of primary care evolve, from what it was traditionally to what it's become? First maybe during the managed care and of HMO gatekeeper era until where we are today. And I didn't warn you we'd be doing a little kind of sweeping history discussion, but why not?
Yeah, that's okay. I'll do my best. I think that there are 2 fundamental pivot points in primary care that I'd like to point to. One is just principally and foundationally, the role of the PCP in history was to respond to patients who needed them and who were present. So before the rise of the hospitalist, this really centered on patients who either walked into their office or were seen in the hospital, because PCPs, many of them, did full spectrum care from soup to nuts. And for family medicine physicians and many NPs and PAs, cradle to grave, delivering the babies and then seeing them into their twilight years. So I think that full spectrum primary care was really a gift of the past. We still see some PCPs doing full spectrum hospital OB, colonoscopies, everything today, but it's a rarity. But that sense of reactive medicine, of providing care to the patients who need it, I think is really important, because value-based care has encouraged a transformation, not just to do that, but also to take advantage of insights from data and technology to proactively reach out to patients. Who should be on your worry list? Who should you be thinking about that isn't walking through those doors? PCPs of yore didn't have the data and technology in order to identify patients in need and proactively reach out to them and invite them in. They had to rely on running into those folks at church or at the ice cream store, or had to rely on their memories to trigger them. And we're in really a different era thanks to the electronic age.
Yeah, go ahead.
Oh, I was just going to mention that I think the changes in insurance that you had alluded to with the HMO era, for me, that really represents the primary care doctor's place in the healthcare system and in the patient's place in the healthcare system. We have not done a great service to our doctors, our practices, and our patients by pitting them against each other sometimes, and by misaligning incentives so that PCPs could make more if patients were kept from care. That was the huge mistake of the HMO era. And I think value-based care, again, is an opportunity to right those ills and align activities that are good for doctors, good for patients, and good for society.
How do you think of the different flavors of primary care now, thinking about it more from the specialty side? Certainly, that sort of full spectrum, soup to nuts, cradle to grave is maybe like a family practitioner, and you have internal medicine, sometimes OBGYN, maybe others that play a primary care role. How do you think about the breadth of primary care?
I believe in inviting as many folks into the fold of primary care who are doing the work of primary care. And so I have known many in OBGYN and many in nurse practitioner, frankly, who have gone above and beyond to care for patients no matter what their circumstances. So I think where I draw the line is that sometimes you have folks saying that they are taking care of the patient full spectrum, but they're really focusing in on a particular condition. And, maybe they'll check in on the blood pressure if it's relevant during that day, but they don't feel comprehensive responsibility. And so I think for me, the definition of primary care today is a physician or other healthcare provider who really does attend to the patient's every healthcare need and is able to coordinate and shepherd them through any episode. Of course, not without collaboration. Sometimes patients do benefit heavily from a specialist's involvement, but the PCP is a really important presence to guide that, to tell them who to go to that's trusted, to integrate information from other sources, and to act on, with the patient's collaboration, the care plan for the patient's total health.
We're almost a year into the pandemic now, sad to say. And I would like to get your perspective on how primary care has fared during that time. Both I know there was an initial shock and some adjustments, and then gone through some cycles. So what has that been like, and what are you seeing right now?
The beginning was extraordinarily painful for the practices we work with. We work with independent primary care providers across the nation. We have, about 800,000 patients under management in Medicare Shared Savings Program, Medicare Advantage, commercial, and Medicaid contracts, about 700 practices in 31 states, and about 7,000 different providers. And we saw that overnight they had a 40 to 60% decline in inpatient visit volume in the pandemic. And it was really a challenge for their bottom lines. And then the other issue was that they had completely inadequate access to protective equipment. So the patients who were coming in, they had to hope and pray that they triaged appropriately and that the patients weren't asymptomatic carriers, because they were using old equipment. They were using repurposed t-shirts to try and shield themselves because they weren't prioritized to receive PPE. And so it was a really scary time. We had a number of office staff and physicians across our network get gravely ill with COVID, and yet they persevered and persisted. And many of them were able to do a quick pivot and leverage telehealth solutions to make sure their patients could continue to access them and make sure that they could continue to be viable and keep their lights open. We also helped them with policy assistance to leverage the governmental financial assistance programs, but it was really scary and very touch and go. Now we're having a little bit of a flashback moment with the COVID vaccine distribution. PCPs have once again been totally left out of the planning. It's really a painful deja vu, because we saw them suffer without PPE, and we're seeing them and their practice staff and their patients suffer without adequate vaccine access. Patients need to be able to get vaccines wherever they are, and now that they're returning to their PCP's offices, I'm worried that we are leaving out our secret weapon, our primary care workforce, to combat the pandemic in its next stage.
I suppose the nature of humans is they can adapt to anything. I remember seeing the wave come across Europe and looking at the Lombardy region of Italy, which is completely devastated and is a wealthy region, not dissimilar really from Boston from a socioeconomic standpoint, and it's just completely devastated. And then it basically came here. Even though we had some warning about it, and it's just amazing to see what it had happened. Where you've got the patients, as you say, coming into the into the practice, and you've got the doctor trying to use an old T-shirt or something in order to, or maybe even a new T-shirt to protect themselves. And it's just been something. And I would say the other thing I notice is that in some places where you've got also kind of a denial of the reality of the pandemic or of COVID, and then you've got people that are on the front lines, or they may be on the front lines. They don't even know they're in a primary care practice, and patients coming in. It's got to be just tough. And even though there's been some adaptation, just kind of being a year into it, and it's just you run out of reserves at some point. You can't run on adrenaline that long.
That's right. And add to that a number of our physicians have served as public health officers and have been the face of the COVID governmental response in their areas. And so in politically disinclined areas to consider the pandemic a real threat, we have seen patients in the community really rally against our physicians who are putting themselves at risk every day to care for patients. It's been heartbreaking in countless ways.
If we look at just maybe more from a kind of economic and operational standpoint at the different primary care practices, are there characteristics of practices that have done better or worse during the pandemic? How would you sort them out?
I think that from our experience, practices who had a diversified financial stream did better, and practices, of course, who had some flexibility from not being on a razor-thin margin. And unfortunately, the reality of primary care in our country is that many practices are on a razor-thin margin. Those folks definitely did better. I think that the diversified funding stream from value-based care meant that they had some shared savings to lean back on and emergency reserves where they might not have in fee-for-service medicine. And I think it really threw into stark relief the fact that we need to pay for health and not just for emergent illness. And so I think that was one thing. I think geographical constraints also led or introduced a variable into how resilient practices could be. We saw for PPE and for COVID vaccination, practices who were in very rural areas without pharmacies nearby, without a health system nearby, and without a hospital to triage to and to collaborate with, they got PPE even later. They had to wait for their own vaccines even later, and use really creative mechanisms to access both. And so our rural physicians and practices were very hard hit during the pandemic. I think also political climate uh, really makes a difference when you have your community allied with you and treating this pandemic very seriously. It's a different feeling. You have you are a hero, and I liken it a little bit to soldiers returning from Vietnam and being spat upon in the streets, right? It's incredible to be putting your life at risk and to be not just underappreciated, but in some cases attacked. And so I think that for our practices who were in like minded communities, they were rallying together, they were enjoying the support of their community. And even though the work was taxing and draining and demoralizing, it was still something they were doing together with their community instead of fighting an uphill battle.
Changing the subject from the pandemic, one thing that I've noticed for a long period of time is the primary care physicians struggling with their business model. So first, you had kind of independent single shingle practices, which still, I guess, are fairly common. And now I'll show. I'm just talking mostly about Boston. I know it does vary, so maybe we can talk about that. But at least what I saw in Boston is you had these single shingle, then they became affiliated with health systems to various degrees, including being, quote unquote, an owned practice. And then you've had more and more that have decided to go into concierge medicine, at least in Boston. And as a patient, it's kind of a weird thing. And we pay for our family premium is well above $30,000 a year, and that's for high deductible plan. And yet, in primary care is supposed to be cost effective and save money for the overall system. But then my primary care physician, wants to get a concierge fee, of thousands of dollars a year in order to be treating me. So it doesn't really seem like it all kind of adds up. And I'm just curious about, why are physicians going into concierge medicine? Is that just a Boston thing? What does it reflect?
Well, there are definitely unique components to markets that are saturated with academic medicines. I mean, you are in the land of Partners Healthcare and Atrius, and so health systems and academics are key in Boston. And I can tell you for sure, Malvern and Sheridan, Arkansas, don't look like that, and there are still very many single shingle PCPs across the country who are doing amazing work. So I think that even so, we did see in one of our first markets, which was Delaware, where we have a really lovely density of fantastic PCPs, we did see the concierge movement sweep across Delaware. We had practices elect to join concierge and stay within the ACO, and we had practices elect to leave the ACO to go concierge, and we had practices who decided to reject the concierge model. And I think we have to examine critically why and zoom out a little bit. When a primary care doctor chooses this path, he or she is called to this occupation to serve patients. Healthcare has demanded more per dollar of PCPs and their specialist colleagues. Low reimbursement, high administrivia. These things are leading to burnout, and concierge medicine offers some promise to emerge from that dark age. But it's not without a sacrifice. I mentioned my own desire to make sure vulnerable patients were always included in my work. And many PCPs feel the same. And obviously, not all patients can afford the concierge model. Doctors who opt into it have to give up these patients. That can be really painful to say goodbye to these fantastic relationships. And I think that there is a light at the end of the tunnel in value-based care. We've seen value-based care solve some of the same concerns that have driven PCPs to concierge and other alternatives. We've seen them regain professional and personal satisfaction through their success because they're able to do well by doing good. They are serving their patients better, and they're making more money by keeping their patients healthy. And so again, the incentives are totally aligned.
Yeah, as you mentioned, primary care practices in particular are often operating on thin margins. And I believe that's one of the things that's actually held back the introduction of technology. So I know that things like web visits, not even telemedicine, but just use of structured, secure email and so on go back at least 20 years, and the adoption wasn't very high until it was sort of forced during the pandemic. And one of the reasons I understood was that doctors didn't want to have email or telemedicine become like the telephone, just one more thing they do that they don't get reimbursed for. Now, recently, there's been some changes in things like telemedicine, remote patient monitoring, chronic care management, and so on. How do you think about the role of technology in primary care and the relationship with reimbursement?
I think that the federal government, through Medicare payment reform, has actually made some good progress in this area, especially in COVID times. The pandemic propelled them to make some changes for reimbursement of telephonic care as well as telemedicine with video. Prior to that, there have been some interesting changes in the chronic care management paradigm where you can make $40 per month by giving a patient 20 minutes of extra TLC, whether through a care manager, a nurse in your practice, other certified patient, or through your own efforts. And so I think that there is an acknowledgement that we need to reimburse primary care providers and practices for the work that they're doing. The telemedicine shift is going to be really interesting to follow. I think telemedicine is a fantastic tool because you can meet patients where they are. We've had patients who work multiple jobs, patients who are long distance truckers, able to get care and keep their appointments and improve their adherence better than if they were required to try and take time off or get extra childcare and come into a visit. And so it is a beautiful option for patients who need it. And it is difficult for practices to work into their very busy offices a hybrid model of care where you may have telehealth deployed to triage patients and see who you can take care of virtually, and time, of course, reserved for those patients who need to be seen and who need to be more closely physically examined. So I think we feel fantastic that Medicare will be paying for telemedicine through 2021 at least, and we are waiting with bated breath to see whether commercial insurers follow suit. I hope they will. I hope that this has been a glimpse into the value of this technology for patients and practices, and an acknowledgement that it should continue.
Let's talk about alternative payment models like ACOs and how primary care fits in, and what the role is for Aledade in that.
Sure. So the ACO model and value-based care more broadly, when you are taking responsibility for the total cost of care for a patient panel, primary care is essential for success in those efforts. We've seen over multiple years history for the Medicare Shared Savings Program, in which you have a group of healthcare professionals who are in an accountable care organization, which means that they have patients who are attributed them through some complex methodology. And then over the course of the year, you see whether those patients cost more money, total cost of care, not just in the PCP's office, but in the emergency room, in the specialist's office, in the hospital. If you can bring their total cost of care down to less than was actuarially expected based on their risk factors, then the government keeps some of those savings and the ACO keeps some of those savings. And that's the business that Aledade is in. Aledade seeks to help independent primary care providers across the nation to do well and succeed in value-based care, regardless of payer. We pursue contracts not just for Medicare Shared Savings Programs, but through Medicare Advantage and commercial insurers and Medicaid on behalf of our partner physicians. And we help them through a proprietary technology platform that introduces data in insightful ways and helps them connect to workflows for outreach to bring patients in. And we provide boots on the ground technical assistance through field teams that are directly focused on helping these practices succeed. The investment in data is huge for us. We not only take pains to get data from the practice in the form of their claims that they submit and health data from their electronic health records, but we also contract with and get data from health information exchanges, hospital portals, et cetera, so that we can let practices know when a patient has been discharged from a hospital emergency room or skilled nursing facility. We think that that embrace of the patient is really critical after that acute event. And then we're also getting claims directly from the insurer. Medicaid and others send us information. So for the first time, the primary care doctor can see what happened outside of their direct practice walls. They can see that a practice has a patient who was admitted to the hospital while they were snowbirding in Florida that they might not otherwise have known about. They can see that a patient has visited 4 different neurologists in the span of 6 months and inquire with that patient what happened, what's going on, how can they recapture that care and quarterback it more effectively. So we definitely do value all of the data that we can get, and we massage it and form it into actionable insights, both at the point of care and for outreach of optimal population health.
I've seen some evidence, at least in Massachusetts, I don't know if it holds across the country or what you see, that ACOs that are physician-driven tend to do better both from a cost standpoint and a quality standpoint than those that are hospital-driven. And I don't know whether that, in fact, holds up nationally or over time, or if you have a perspective on it.
Definitely, that is a national data truth. So it is absolutely true that physician ACOs across the country have done better in taking better care of patients and decreasing costs than hospital and health system led ACOs. And it makes perfect sense. If you think about it, there's this issue of demand destruction that hospital led ACOs are fighting against, because how do you take better care of a patient? How do you save money on a patient's health? You keep them healthy. You keep them out of the emergency room and out of the hospital. You reinvest in primary care. And that's what we've done. We make sure that we spend more on primary care. And by doing so, we see proportionally less spend, and it's replicable, and we can do it across geographical diversity. We see declines in emergency room utilization, hospitalizations, hospital readmission, SNF length of stay. It's amazing what primary care providers can do with the right data and the right workflows.
I'm happy. It makes sense intuitively that it comes out that way. One of the things I've been struck by is that you've had in the economy, technologies and trends that have allowed other sort of businesses to operate at smaller scales, like a consulting firm or many professional services. And yet in medicine, there's a lot of consolidation, which is, I think, mostly because of market consolidation for more power negotiating with insurers, and then just some of the ways the reimbursement and the regulation works to make it so complex. And it sounds like Aledade may be doing something to help to counteract that and bring things back more toward the natural course, or maybe just more of a force equalizer for these smaller physician practices.
Absolutely. These independent physicians are fierce and wonderful advocates for their communities, and we are absolutely privileged to give them an option to stay independent.
If we were looking a year ago, I'm not sure, and I asked you about what you see happening, I'm not sure what you would have said, or whether anybody could predict exactly what had occurred. So I just preface my next question with that. But what are some of the key trends that you foresee for 2021 and beyond?
I can tell you what I hope. I hope that practices across the country learn about these successes and take heed and understand that they truly will do better if they can transition out of fee-for-service and into alternative payment and value-based care models, that they will be more satisfied, that they will take better care of their patients, that they will be able to financially gain and have their reimbursements start to equalize a little bit with that of their specialist colleagues. It is possible, but it's really hard in the real world to have one foot in the fee-for-service canoe and one foot in the value-based care canoe. Different workflows are required. Different payment begets different activities and behaviors. And so I think that we will invest more as a government in these payment models. I think commercial insurers are starting to follow suit. Medicaid isn't far behind. And so my hope is that we will see this movement continue to gain momentum, and value-based care will grow and become more realistic as a primary care reimbursement source, such that it can compete fee-for-service out of business.
Well, maybe it does make sense to answer the question more in terms of hopes and what you're doing to make it happen. So that probably is a savvy way to answer. A last question, Ellie, I want to ask you is about what books are you reading, and if there's anything that you recommend for the listeners.
Well, if I tell you the truth is that I read an embarrassing amount of dystopian fiction, but I don't think that's what you're asking after.
You say like when dystopian fiction, you mean like reading the newspaper?
Exactly, exactly. You'd think that I would want an escape from 2020, but I did just finish a book called Little Bets by Peter Sims, which details the promise of a culture of safety around experimentation and really thinking about how to protect your organization and encourage inevitable failures and fail fast, and the value that can then arrive from progressive small scale experiments and iteration. But if I were to recommend one group to your participators, I would probably say it would be Switch by the Heath brothers. It's kind of an Aledade Bible of sorts for engagement and winning hearts and minds, or in the book's parlance, elephants and riders. So it's been a valuable part of informing what we do.
Excellent. Well, Emily Maxson, Chief Medical Officer of Aledade, have enjoyed speaking with you today about everything from growing up with a fertility specialist as a dad to Switch and primary care there in the middle. So
thank you. My pleasure.
You've been listening to the Health Biz Podcast with me, David Williams, President of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.